Hello everyone, my name is Dr. Muhannad Al Haddad. I'm a bariatric surgeon from Jabra Hospital. Obesity in adolescents has been a major public concern over the last 17 years. It's estimated that 34% of adolescents in the United States do actually suffer of some form of obesity. And the figure is not that far off here in Kuwait and the Middle East. I think the figure resides between 26 to 28% prevalent obesity in the Middle East. Just like many other medical conditions, the prevalence of obesity does actually varies by racial background, cultural background, and socioeconomic factor. For example, in the United States, they found that the highest prevalence of obesity does actually is seen amongst Hispanic kids. I think the figure is about 26%, as in opposed to the lowest incidence of obesity in the Asian American, which is 9%. And of course, the complexity of obesity doesn't necessarily start from giving birth, but the parents' health status and their weight does somehow contribute to the overall weight of the child. Obesity when parent is believed to increase the risk of obesity in child by 2 to 3-fold and up to 15-fold if both parents do actually have obesity. The etiology of obesity amongst adolescents and children is very complex and very deep. Going through it shallowly, you could see the genetic contribution, endocrine contribution, but the behavioral and environmental factors that actually causes obesity are believed to constitute 95% of the cases. Luckily, those group of patients whose obesity is mainly contributed by behavioral and environmental factors seems to do well in terms of treatment, either non-surgical or surgical intervention. The American Academy of Pediatricians and the CDC have formulated a classification for obesity amongst adolescents, very similarly the one that actually seen in the adult. So they classify them into 3 different classes: Class 1, Class 2, and Class 3. Class 1 obesity is a BMI above 90% of the 95th percentile. Class 2 is the BMI of more 120%, less than 140% of the 95th percentile, or BMI of 35 and less than 40. Obesity class 3 is BMI more than 140% of the 95th percentile, or BMI more than 40. It's very important to mention here, the weight isn't the only indication for surgery in the adolescent population. In fact, there is more into it I will be discussing later on in these slides. But the indication for adolescent MBS is obesity type 3 or obesity type 2 with a clinically significant comorbid condition. The comorbid conditions are mostly seen in adults, with the exception of idiopathic intracranial hypertension and slipped upper femoral episis, whereas obstructive sleep apnea, type 2 diabetes, and GERD are seen in the adult population too. Now, there are indications, there are contraindications. However, the contraindications in the adolescent aren't actually an absolute. They're only a relative contraindication that need to be taken into account once a decision of surgery is taking place. Medically correctable cause of obesity, substance misuse, ongoing or recent history, planned pregnancy within 12 or 18 months, or a current pregnancy. Last, but certainly not least, the ability of the patient or his family to adhere to a strict lifestyle is very important selecting criteria. Has been shown by data that people who actually lose weight in the pre-operative time do actually respond well after surgery, and the reason behind that, because they are self-programmed into changing their lifestyle and adhering into a strict post-operative order, giving better treating team. Now, like we said, the BMI, the weight, isn't the only indication for surgery. Patients must have a certain setting for before the actual adolescent patient is referred to the surgeon, and that's by the means of MDT, the multidisciplinary team, which involved pediatric specialists, registered dietitian, mental health specialists, and exercise specialists with bariatric or pediatric surgeon. They usually set a certain program and time scales where they subject adolescent into a certain program, and through this program, most of those patients do actually lose weight. lose weight, and only a small fraction of these patients get referred to a specialized center for bariatric surgery to take place. Once the MDT decide to send a patient for a specialized surgeon and a special center, he does follow exactly the same path as an adult, obese adult. So they go with laboratory tests, complete blood count, renal function, liver function, micronutrient, vitamin B1, B6, B12, folic acid, zinc, magnesium, copper, iron, and profile. And these results need to be repeated with the exception of folic acid and zinc 2 months after surgery, at 6 and yearly ever after. It's very important to know that data had shown that adolescents do actually suffer from thiamine deficiency in the post-operative period, as if you compare them to adult group, and hence it's very important to give vitamin B1 in the post-operative period for adolescent post-surgery for at least 6 months. Radiological workup is very similar to those seen in adult, with the exception of bone and dual energy X-ray. Of course, upper GI endoscopy is based on individual patient for a Helicobacter screening. But the question is, does surgery work in adolescents and children? Does it actually contribute to weight loss? There are many articles out there. The 2 most important articles are the Team Lab and the Adolescent Morbid Obesity Surgery. The Team Lab is basically a multi-centric prospective observational study of adults undergoing bariatric surgery. So they had 242 patients in 5 different centers in the United States. Most of those cohorts demonstrated high metabolic factor. So what they did is they operated the patient, they followed them up, and they compared them against each other, and they compared them against an adult who underwent a very similar surgical intervention. The adolescent comorbid surgery is another big prospective randomized comparative observational study that actually took place in Sweden, where they recruited 80 patients who underwent strictly Roux-en-Y gastric bypass. So in terms of weight loss, you could see clearly here in the arm, Roux-en-Y gastric bypass and the Amos group, and the Roux-en-Y gastric bypass and the teen group, and the sleeve group and the teen group did very well in weight loss in the post-operative period of up to 5 years. You could also notice that the near equivalent result between the vertical sleeve gastrectomy versus gastric bypass. But it's very important to mention that the Teen Lab have released a crucial data stating that patients who underwent Roux-en-Y gastric bypass, 70% of them did actually suffer of nutritional deficiencies. And that had led to the statement of ASMPS to name sleeve gastrectomy or sleeve gastrectomy to have the higher edge as a primary choice of surgical intervention in the adolescent population. Now, you could say the Teen Lab had involved gastric banding. Of course, gastric banding, adjustable gastric banding, has grown out of fashion in the adult population. In a similar fashion, it has grown out of fashion also in the adolescent population. But surprisingly, the bariatric ongoing longitudinal database that they looked up on 300 different centers in the United States, and they followed up the patient who had laparoscopic band adjustment versus Roux-en-Y gastric bypass. Surprisingly, weight loss was quite similar between 2 groups. But the problem was the group of adjustable gastric band had more complication in the short term in comparison with Roux-en-Y gastric bypass, and hence the surgeon don't actually prefer, or pediatric surgeon don't actually prefer to do adjustable gastric band in the pediatric population. Now, in the same vein, obesity-related comorbidities and outcomes. The disease-related comorbidity seems to respond very well in surgery. If we talk first and foremost the cardiovascular disease, which seems to have a dose-dependent increase in mortality, i.e. patient with childhood obesity have more than 3-fold increase to die from CVD at the age of 50. And a recent release of longitudinal data from the Teen Lab had suggested that bariatric surgery does indeed have a significant effect in the resolution of risk factor that somehow contribute to cardiovascular disease. Type 2 diabetes is another major concern in the adolescent population. Very similarly, it's a major concern in the adulthood population. The problem is the adolescent with type 2 do show a more progressive course, and the fact being that there are a rapid decline in beta cell that's 4 times faster than seen in adult. But luckily, again, data from MOS and the teen lab had shown a great response of resolution for type 2 diabetes if you compare them to an adult. So, in fact, the resolution of type 2 diabetes after surgery in the pediatric population is far superior than the resolution of diabetes type 2 in the adult population. Obstructive sleep apnea, which makes up 1/3 of children and adolescents with obesity, also does have a severity that seems to increase with age and has its own morbidity and mortality independent of other risk factor. Data released from the adult population suggests that surgical intervention do actually reduces the incidence of obstructive sleep apnea by actually reducing the weight. Non-alcoholic fatty liver, NAFLD and NASH. NAFLD, of course, it's a very generic terminology that encompasses a wide range of diseases from fat in the liver to liver cirrhosis, hepatocellular carcinoma, even end-stage liver failure. And it has been seen in 9% of children between the age of 2 to 9. In the teen lab study, they biopsied 165 patients. Random liver biopsy was taken. 60% of those biopsied patients had NAFLD and then 10% had NASH. And we believe from looking at adult previous study in adult population that bariatric surgery, namely Roux-en-Y gastric bypass and sleeve, does actually have a significant, substantial improvement in the resolution of such disorder. Idiopathic intracranial hypertension. It's rarely seen in adults. It can be confined mostly to children and adolescents. It's characterized by elevated intracranial pressure with no clinical or logical evidence, may lead to permanent visual impairment. However, there are no consensus or study out there to prove that bariatric surgery does actually solve the problem. But according to expert opinion, that surgery or surgical intervention should be actually reserved as a last resort in the treatment of idiopathic intracranial hypertension should medical therapy fails to produce an effect. Sapphire and Blount's disease also seems to respond well to metabolic surgery. Slipped upper femoral epiphysis. There's a recent study in the United Kingdom where they compared 70 patients under the age of 16 who had slipped upper femoral epiphysis, and they found out that there is 2 standard deviation increase on BMI on those group in comparison, if you compare them to their peers with no slipped upper femoral epiphysis. Therefore, someone may argue that obesity is a major risk factor in the etiology of slipped upper femoral epiphysis. By losing weight, you may actually be on a less risk of getting SUFE. GERD is another indication, very similar, follows the same path as an adult, but the preferred option here is actually Roux-en-Y gastric bypass. In conclusion, obesity in adolescents has become a major health concern over the last 17 years. MBS is clearly one of the main obesity treatment modality in adolescents. Patients who are being considered for medical intervention should be referred to a special MBS center. Vertical sleeve gastrectomy, Roux-en-Y, as I showed you in the graph, to have the same effect on weight loss, but the fact because of the severe nutritional deficiency seen on both studies post-Roux-en-Y had made vertical sleeve gastrectomy as the primary option for treatment of obesity, given patients have no gastroesophageal reflux. Thank you.